One. We are live, ma'am.
Good evening and good morning to the audiences across the globe. I welcome you to this academic platform of Women in Nephrology India. I'm Dr. Padmini Sarkanuru, consultant nephrologist at Medica Hospitals, Kolkata, and will be your host for this symposium titled Membranous Nephropathy, Meet the Masters. We all are aware that membranous nephropathy is a common cause of nephrotic syndrome in adults. Our understanding of its pathogenesis and management has undergone a paradigm shift in the last few years. To enlighten us further on this topic, we have an esteemed panel of experts in membranous nephropathy. To begin with, let me introduce the moderator for the entire session, Dr. Arpita Rai Chaudhary. She is Professor, Department of Nephrology, IPGMER, Kolkata. She is also the Joint Director of ROTO. She is an excellent teacher and a human being par excellence. Over to you, ma'am.
Thank you. Thank you, Padmini, for your kind words. And as Padmini introduced the disease, that it's a pathologically defined glomerular disease that occurs in all ages, and nearly 80% of patients, there is no underlying cause. So we call it primary MN. Though there is a confusion now arising in whether whom we will call the biomarker-based primary or secondary MN, that we will learn over time. And since plateau has come for the major antigen-based disease, there has been a paradigm shift in disease diagnosis and monitoring. We knew that the patient outcomes are variable. For a long time, it was governed by the rule of thirds. And we know after the good allocated immunosuppressive therapy of Ponticelli regime, we probably are getting less and less kidney replacement therapy. But there were problem too. So newer agents were introduced, relapses were frequent. We need to use more immunosuppressive therapy in the situations where we were comfortable using some other agents which are not as carcinogenic as MPR is or as infection prone as that. So with the allocated therapies that we give our patients, we look to see what is the best depending on the newer mode of risk stratification. And one part of today's session will be dedicated to epidemiology of Indian membranous nephropathy. Published document from AIIMS Delhi will be delivered by a competent pathologist, Geetika, and other part will deal with the clinical trial evidences from 2 single center Indian experiences, which were showcased in various Indian and abroad meetings. So lastly, we will listen to Professor Joy Radhakrishnan from Columbia University, who will guide us through the past, present, and future of membranous nephropathy, which I think will be an essential guide for youngsters to grasp the pathogenesis, evolution of treatment, and where the future may embark upon. Thanks, and expecting a good experience, good academic feast. Over to the anchor of the program, Dr. Padmini. Carry on, please.
Thank you, ma'am. So we start this evening, and the first topic that we'll be discussing is a snapshot of the Indian membranous nephropathy that would be presented by Dr. Geetika Singh. She is the Associate Professor, Department of Pathology, All India Institute of Medical Sciences, New Delhi. The session will be chaired by Professor Dr. Joy Radhakrishnan. He is the Director, Clinical Services, Nephrology Division, Columbia University, New York. He's also the Associate Editor of Kidney International and the founding editor of Kidney International Reports. He's a Global Education Ambassador of the International Society of Nephrology. Dr. Manjusha, she is the Head, Department of Nephrology, Gandhi Hospital, Hyderabad. And Dr. Megha Open, she is the Additional Professor, Department of Pathology, Nizam's Institute of Medical Sciences, Hyderabad. So over to you, ma'am, Dr. Manjusha, ma'am, to carry forward this session.
Yeah, thank you. Thank you so much. Good evening, everyone, the august audience out here, and Professor Jai. Welcome for this first of its kind session, Meet the Master program. So as has been said, membranous nephropathy is an interesting area. So without much ado, I call upon the speaker of the first session, Dr. Geetika Singh, who needs no introduction, but it's my privilege to introduce to the audience out here. She is the additional Associate Professor of Pathology, AIIMS, New Delhi. She has done lots of work in membranous nephropathy and has good number of publications as well. and also her interest is in renal transplant pathology. Over to you, Dr. Geetika. Please apprise us about the membranous nephropathy, the pathology concerns about it. Over to you, Dr. Geetika.
Thanks so much, Dr. Manjusha. So while I share my screen, I'd like to thank Professor Arpita for this opportunity to speak to this wonderful group. And a big shout out to all women in nephrology. We're all rock stars. It's very difficult sometimes to manage it all, but I think we are doing a tremendous job. And it's so great to have Dr. Jay here. He is a stalwart in his field. So I hope to be able to contribute a little bit. So I'm going to be talking very quickly, 15 minutes, about our experience of our patients of membranous nephropathy. I want to just quickly start by talking to you about how we diagnose it, right? So we are looking at our standard 4 stains, and we are looking for thickened basement membranes, which is what we're expecting in a membranous. And then we will go into good high power on a good Jones silver methenamine, and we will look for evidence of subepithelial side deposition. And we can see this here in the form of spikes. So you see these black lines going up. This is, of course, an oil immersion image, so really high power. And these spikes tell us that this thickening of the basement membrane is because of a problem on the subepithelial side. And this is what we're basically seeing on that Jones silver methenamine. So the GBM reaction to the subepithelial immune deposits. And we would confirm it with a full-on immunofluorescence panel. And what we expect is this carpeting of granular IgG, and it's usually accompanied by C3, and it's polyclonal, so you'd get kappa and lambda there. And we don't really need EM in most cases to diagnose it. It's good to have it. There are problem cases, of course. But this is what a classic stage 2 to stage 3 membranous nephropathy would look like on an EM. And you can see these electron dense deposits, and you can see the same GBM isodense material going up. And that represents the spikes, the GBM reaction. So of course, this GBM, this capillary wall is very thick. And you can see how the podocytes have completely fallen flat. And it's not difficult to imagine that these patients are going to be heavily proteinuric. So before the biomarker for primary membranous came in, we were still trying, even from the pathology side, to try and give some indication of primary versus secondary MN as we were looking at our cases. And what we were looking for on light microscopy would be, well, are we seeing extra stuff? Like, is there mesangial and or endocapillary hypercellularity? On immunofluorescence, you would be paying attention to, well, what does the panel look like? And where is the immunofluorescence? Is it only capillary wall? Is there a lot of mesangial or extraglomerular deposits? If you're lucky, you might see some tissue ANA staining, which is of course an artifact, but it helps. Then in the panel, we would be looking at complement very carefully, wherein we would say, well, if there's a dim C3 that favors primary, but if you've got a lot of C3 and maybe some C1q there, then you may want to hint towards secondary. I'll talk about the subclasses later. That's still a relatively recent phenomenon. On EM, if we got to it, we would be checking for mesangial location EDDs, and we would be hunting for tubulo-reticular inclusions. Of course, we understand that the secondary membranous is predominantly driven by the autoimmune process, most commonly lupus class 5, where we're expecting that circulating immune complexes are going and sitting there in the subepithelial space. And we could even have planted antigens, which is a common understanding for HBV related, for example, membranous, versus the primary membranous, where we feel that the pathogenesis, as we understand, is an organ-specific autoimmune phenomenon directed against photocytic antigens. So we were always trying to do this as we looked at our cases, and of course, we would need very good clinical correlation. So as Professor Arpita and the rest of the group was discussing before we got on, we need that crosstalk between the pathologists and the treating nephrologists. So what did we do? It's a small little look at our patients, which was published in KI Reports in 2020. Of course, it had already been a while. PLA2R story came out in 2009, and the Thrombospondin story came out in 2014. And it explained that primary membranous, so 70% PLA2R related and maybe 2 to 5% thrombospondin related. But Indian data was still not very comprehensive and out there. So what we did is that we wanted to look at our patients at baseline when they were biopsied and to determine their PLA2R and thrombospondin status. The PLA2R we were looking at both from tissue side as well as the sera. And for thrombospondin, at that point, we only had access to tissue staining. So we were looking at 4 years data from 2014 to 2017. We needed adequate tissue relevant clinical details, and we were very lucky that our nephrology team had a biorepository running, and we could get quite a few number of sera which were collected at baseline and stored in their biorepository. So we're very thankful to them for that. So as we were recruiting our patients, we wanted to know whether they were clinically primary or clinically secondary. And this was a battery of tests which was done in each and every patient, which I'm sure that the nephrologists in the group would maybe agree with, that you really need to go into the depth to see whether there is any common secondary cause. So there would be an HBS antigen, anti-HCV serology, syphilis serology, a good autoimmune workup with ANA, dsDNA, serum complement levels, relevant investigations to rule out malignancies. So chest radiograph, abdominal ultrasound, urine for atypical cells, SOB, females mammogram, and PSA for males, and history of any intake of drugs that are known to cause MN. So this was done for every patient, and then there would be a clinical assessment of whether the patient is primary or secondary. Along with that, there were baseline investigations which we had for every patient. So basic urine routine, spot urine PCR, serum albumin, serum creatinine, and we would want to know history of any prior immunosuppression. So what did our cohort look like? We had around 4,000 biopsies received in that duration, out of which 405 cases, so approximately 10.3% of our patients were membranous nephropathy. And you can see out of those 405, only 216 had adequate tissue and clinical data, and these were enrolled as part of this study. And sera was available in around half of them, so 110 of them had available sera. So the first step for us, which was the challenge, was standardizing the PLA to our IF. And with experience of many years now, it's one of those fiddly stains. You've got to be careful with it. We standardized it on a paraffin immunofluorescence protocol, and you can see it's bright red here. This is phycoerythrin staining. This is a good positive case. In some labs in India, I know that immunohistochemistry is used. And it's one of those stains where you need experience to figure out a good positive versus negative. Always good to run your positive and negative controls. This was a patient of minimal change, and this was a negative membranous. So the IF was standardized. The serum ELISA was standardized. This is the classic commercially available kit. More than 20 units per ml was considered positive. Thrombospondin IHC was standardized. Again, it's a fiddly IHC. You've got to be very careful with interpretations, but this was a good positive case. This is a negative case with maybe a little bit of linear and that podocytic dot-like positivity, but this would be negative. And here you would see a good co-localization along the capillary walls. So that's your thrombospondin positivity. Of course, at this point of time, all the new antigens were not there yet, but I'll briefly just discuss that later. So in 216 patients, this was our breakup: 184 adults, 32 pediatric. That's our median age is 34. We had a wide range of patients. It does really affect any age group. We had more males, and that was the mean duration of illness. Our patients were 50% nephrotic syndrome, 25% were nephrotic range proteinuria, and 25% was subnephrotic proteinuria. Of course, some of them did have history of immunosuppression. That was around 36% adults. So they came to us after already receiving something. And all children, because as we know that children would be given an empirical trial of steroids before they would even be biopsied. Primary was, of course, most common, and in secondary, our causes were most commonly SLE, followed by Hep B and Hep C. So when we looked at the histology, we were looking at the old parameters. Okay, is there mesangial expansion, hypercellularity? Yes, 18% of patients did have it, quite significantly with a significant p-value that did correlate with the secondary cases. So yes, we do still think that that's an important histological thing. You want to ask your pathologist when you're looking at your case, how is the mesangium? Evidence of progression in the form of secondary segmental sclerosis, yes, 13% patients, presents in 2 cases actually. And I will discuss it, but both those patients were PLA2 are positive actually. IFTA more than 25% in a small percentage of patients, 8.8%. So we were picking up our patients quite early. When we saw mesangial hypercellularity, there was a higher chance that they were secondary. But interestingly, when we were looking at the IF panel, if we just looked at the glomerular IF staining, we couldn't really differentiate. So when we were looking at our cases, if I saw a lot of C3 there and some C1Q, some of them would turn out to be primary PLA2R related membranous. So after this study, we stopped really paying too much attention to the glomerular IF staining. If you see extraglomerular staining, yes, I mean, as a pathologist, you would really point towards secondary. Now, when we looked at our PLA2R data, what did we get? So if you look at the primary membranous, 52% of them were PLA2R positive. And interestingly, 11.5% of our secondary membranous were tissue PLA2R positive. When we looked at the sera, pretty similar. 59.7% sera PLA2R positive for primary. And if you looked at secondary, there were still those odd cases which were serum PLA2R positive as well. And so two things I think to bring out of there. If you take tissue and sera together in primary membranous, the prevalence of PLA2R related membranous became 72.8% of primary membranous. So our Indian patients were really falling into the same types of patients that was being described in literature elsewhere. Our patients were behaving quite similarly. Around 70% of the primary membranous were PLA2R positive. So that's one point which comes out. Second point is if you do tissue and sera, it seems to help because we're picking up more patients, and we look at that. And the third point is that just as was reported with anecdotal cases, and there was a large series from Arcana as well, some secondary membranous patients were PLA2R positive as well. So whether this is a Hep B related membranous or in the background of Hep B, which is not really hitting the kidney, the patient has PLA2R related membranous. So, that's a big discussion you want to have with your nephrologist. And between tissue and serum PLA2R staining, our kappa value was 0.61, so moderate concordance. So definitely a combined approach is beneficial. Even if you're sending sera out, it's a good thing to check with your pathologist and get the tissue staining done as well. And again, as was reported in other studies, we had our outliers. So we had those combinations wherein, tissue was positive in a case, but the serum was negative. And this was in 12 patients, 6 of which had history of prior immunosuppression. So if you look at this Gaussian curve of how the PLA2R in terms of serum and tissue, we would think that these are those patients who've received immunosuppression. They may have gone into some form of remission. So their serum is negative, but their tissue staining is still persistent. Of course, if you're picking up patients very early on in the disease, the same pattern of tissue positive, serum negative could be explained by the sink phenomenon, which is that whatever is being produced in the sera is all going into the kidney. So you're just not picking up enough in the sera. Now, that seems like an easily explainable situation, but we also had the opposite wherein you have tissue negative, but serum positive. As a pathologist, I would first check technical. I have to be very, very technically confident that my positive control was good, this tissue is good, there's no fixation issue. But once I've excluded all of that, the only other explanation possible is there's some epitope differences between the antibody which we're using to detect tissue PLA2R and the ELISA that we're using to detect the sera PLA2R. But again, we had all different combinations. So combined approach is good. You're going to pick up more of your PLA2R related membranous. What about thrombospondin? We stained 176 cases, of which only 6 patients were positive. 6 patients were positive. 1 was a lupus patient. 1 was a technically pediatric patient, 17 years of age, so under 18. And there were 2 cases who were dual positive for thrombospondin and PLA2R. So we were seeing, again, all the variations which have been described in patients from other populations. And the explanation here is most likely that there is a common epitope, so that antibody is coming positive for both. So our prevalence was 3.4%, good in the middle of 2 to 5%. So Indian patients are quite similar, but we didn't find any association with malignancy. I did have one case after this study, which came up with a chromophobe renal cell carcinoma, but that's it. So our experience with thrombospondin, I think in my whole experience till now, since 2014, I have 6 plus 2. So 2 additional thrombospondin positive cases, one of which has an association with a renal cell carcinoma. So how did we compare to other Indian studies? There's a large study from PGI Chandigarh, but that's the percentages. And there's a lot of variation depending on the way it was tested. There was no thrombospondin data out there for Indians till we put our work out there. But overall, it seems that membranous nephropathy in Indians is very similar to other reported populations. What about pediatric? We had a good sizable number of pediatric membranous. And in the pediatric nephrology, the PLA2R, I think it didn't explored as much as it did in adult nephrology, but 44% of our patients were PLA2R positive based on tissue sera testing. We even had one case of thrombospondin positive. So they warmed up to the thing, and the seras were sent for PLA2R very easily for all their membranous patients as we got our data out. And this is again similar to pediatric reported populations outside India of around 45 to 50%. So 40 to 50% of the pediatric patients are also PLA2R related membranous. A few clinical histological correlates. We found more proteinuria in PLA2R positive group. There was good correlation between the titers and the 24-hour proteinuria. Both our crescent patients were actually PLA2R positive. They were not secondary. And the PLA2R negative cases had more significant IFTA. So that was kind of where we were when we published in 2020. Since we've introduced PLA2R and thrombospondin for all our patients now on a routine basis. We're trying to do a little more for our MN patients. We now run IgG subclasses for all of them, and the correlate is that the PLA2R related membranous is usually G4 G1 positive, G4 more than G1, but in our experience, they're pretty similar. It's very difficult. But this G1, G4 positive, G2, G3 negative is, I would say, very, very suggestive that the patient is going to have a PLA2R positive membranous, whereas if it's G1, G2, G3, that's a more of a secondary membranous. So it is sometimes useful in problematic cases and when there is clinical confusion between primary and secondary. What are we doing about the new markers? In our lab, we are still in the process of standardizing. So we are on the process of standardizing these three, exostosin, NEL1, and SEMA3B, and hopefully we will have some data out there. But it will take its time. It'll take a year or two. And then maybe we will also have, I would love to hear from Dr. Jay, is it already there? At Columbia, are you getting these kind of all these antigen associated reports? But I'm happy to say we've just recently been funded from ICMR to get all these markers sorted and get some Western blotting done as well. So hopefully we should have some data out there. A little, if I have a minute, a little more of what we are doing for membranous patients. Well, we use C4D very frequently. Well, not very frequently. In difficult cases, the late membranous who are just negative on IF and we're having trouble with them, C4D lights up. And then we wanted to investigate a little more on complement, and we did some lectin pathway marker staining. And this is, again, I wouldn't say it's very recent, but there is now a greater understanding that membranous nephropathy is really driven by the lectin pathway of complement. And you can see that even in the tissue, because here you've got the mannose binding lectin, here you've got ficolin and MASP. This is mannose associated serine protease. And you see how it really lit up. We did it on a spectrum of patients, and it's the membranous nephropathy which just lights up for the lectin pathway markers. I think it should be a good target as people are working on anti-complement therapies. And of course, MAC lights up as well. So that's it from me. Thank you. I'd like to acknowledge, of course, my mentor, Professor Amit Kumar Dinda, and everybody who I worked with, and some junior residents who really helped in standardizing the PLA2R, thrombospondin, and my technical staff. Thank you.
Thank you very much. I'm going to just say that this is, we were very happy to receive your article in KR Reports. and I hope we didn't give you too much of a hard time in getting this published.
We were just happy to get it through, Dr.
But it is wonderful.
Reports.
And I think, and we are very supportive. So as you can see, Arpit also knows this, that we are really looking out to encourage, submissions from the subcontinent. And, of course, it'll have to pass peer review and everything. But, thank you very much for, submitting to us. And we're looking forward to your next level of staining, which once it's approved. So just in terms of your questions, so we haven't done this this array of antigens in all patients because the main reason is it takes a lot of time, as it's getting the reagents up and running and doing it in the 30% of PLA2R negatives. We do THSD7A, but that's about it. But for research, we've done all the others, and it really takes a lot of technician time, as to keep adding on the antigens. So, and it's not been shown to change as yet therapy, right? So we are in the early stages, and hopefully with the proteomics approach, it might be much easier once we get these these tests standardized. But one thing I wanted to ask you was about the you sort of briefly went past it, but do you look at, the pediatric stain? What is it called? SEMA, right?
So it's one of the the
yeah,
semaphorin 3B. Yeah. So so I've got the SEMA 3B in the lab. I've run it on the controls, but I haven't started running it on cohorts. So we're doing it as part of a study. So we're still at the standardization stage, but those are the 3 next antigens that we are targeting. So we're going to do the NEL1. I know NEL1 has started in India. So in one private lab, they have started the NEL1. I think exostocin is also there with them. But I would say in the next 6 months, we should be running with these 3 additional, the NEL1, the exostocin, and the SEMA 3B. And beyond that, I have seen a case of, for example, CIDP with membranous. And then I think the protocadherin 7 has been described to be associated with that. But then they're so one-off that I can't justify buying the antibody.
It's expensive. Yeah, I agree. So it's not, I think as time goes on, we'll get more data. But and we're looking at I saw your Moore's law, line that you keep looking, you'll keep finding, but that by the time it reaches clinical practice for ultra rare antigens, it's not clear how viable this whole process is going to be. But anyway, that's a wonderful overview of the pathology. I must say I learned a lot. Thank you. I wonder if there are any questions from the audience. Audience, please type in your questions in the chat.
No, we have separate 15 minutes at the end of the session for the question.
Okay. Thank you.
Okay.
So Gitika, please stay back with us. Your questions may come at the end. I think you will enjoy. Padmini, over to you for the next session.
Okay, so quickly we move on to the second session of the evening that would be presented by 2 budding nephrologists from India, Dr. Tarak Chaudhary, who is a resident at IPGMER Kolkata, and Dr. Megha Sehgal, who is a resident at Nizam's Institute, Hyderabad. They will be presenting their studies on membranous nephropathy that was showcased in the ASIN 2021. The session will be chaired by Dr. Swarnalata. She is the additional professor and unit head, Department of Nephrology, Nizam's Institute of Medical Sciences, Hyderabad. Alongside her would be Dr. Arpita Rai Chaudhary, ma'am, and Dr. Joy Radhakrishnan. So over to you, ma'am.
Thank you, Padmini. I think we may invite residents to present their presentation. So, Megha, if you may present your work.
Megha, please.
Good evening, everyone. Are my slides visible?
Yeah. Yes, Megha, your slides are visible and you're audible. Please go ahead.
So before starting, I would like to thank the organizers of WIN India for letting me be a part of this August program. So I'm Dr. Megha. I'm a senior resident nephrology from NIMS Hyderabad, and I would like to present an overview of the clinical profile and outcomes of primary membranous nephropathy, our experience over the last decade. My slides are not moving here. Are they moving? Yeah, okay.
Yeah, so, now it's moving.
Yeah. So before starting, just showing you that this beautiful city called Hyderabad and hospital that is on the left, and all of you are welcome to please come here. So starting, my study was a single center, that is from Nizam's Institute of Medical Sciences, Hyderabad. It was a retrospective observational cohort study, which studied the clinical profile, response, and outcome of the various immunosuppressive regimens that were used for treatment of primary membranous nephropathy. Now, going to the study design, we studied 129 patients with biopsy-proven primary membranous nephropathy who presented to our institute from a period of 2010 to June 2020 with a minimum duration of follow-up of 1 year. So the inclusion criteria for our study was that they should be biopsy-proven membranous nephropathy with either serum or histological plateau positive, and they were attending the OPD department of our hospital, nephrology department, and they should be adults, that is of age more than 18 years. The exclusion criteria, obviously being a pediatric population, was not included in the study, or if the patients were already end-stage renal disease at presentation, or they had a renal or they had a transplant before, or patients with secondary glomerular diseases like SLE were not included in this study. So the treatment protocol of what we gave to our patients were the following. Some patients were treated based on the KDIGO guidelines. Some patients were treated with conservative therapy, some with modified Ponticelli, some with combination, and some with de novo. So starting with the treatment with conservative therapy was given to all the patients, like in the form of dietary modifications. They were told to have a salt restricted diet. And also depending on their creatinine protein restriction was also advised, so not much according to the KDIGO guidelines. Then they were also told regarding the RAS inhibition, and they were started to decrease proteinuria depending on their blood pressure. The RAS inhibitors in the form of AC inhibitors or ARBs were titrated according to their blood pressure and how much they could tolerate. And if they were dyslipidemic, or if they were having any other problems like any thrombosis, they were started on statins and anticoagulants and diuretics to take care of their edema. Now the other patients who did not respond or who were having a high grade of proteinuria, they were given modified Ponticelli. Modified Ponticelli treatment, as we all know, depended on 6 months of alternating pulse steroids of 1 gram IV methylprednisolone for 3 days, followed by oral steroid dose at 0.5 mg per kg per day for 27 days on alternative 1, 3, and 5 months. And cyclophosphamide, which was at 2 mg per kg per day on alternative 2, 4, and 6 months. Some patients, especially now, they were started on de novo rituximab, patients who could not be given steroids for multitude of reasons. They were started on de novo rituximab. Initially, earlier, we were giving rituximab weekly for 4 doses at 375 milligram per meter square IV. Or now, because of more compliance, better compliance, now we have started giving 2 doses, 1 gram, 15 days apart. And some patients receive something called combination therapy that was actually more of physician dependent. So patients who had received 1 cycle of modified Ponticelli regimen and did not respond to it after a waiting period of 6 months, they were started on various combination therapies based on the physician's choice. Either they were given tacrolimus based on their weight as 0.05 to 0.08 mg per kg per day in 2 divided doses, or MMF 1 gram per twice daily, or rituximab, or some people were also started on a second cycle of modified Ponticelli. So the outcomes were defined as followed. Complete remission was in our study defined as KDIGO guidelines as 24-hour urine protein of less than 500 milligram per day. Partial response was defined as a 50% reduction of proteinuria from baseline and between 500 milligram and 3.5 grams per day with a stable GFR. No response was defined as less than 50% reduction in proteinuria from the baseline. Relapse was defined as a recurrence of proteinuria of more than 3.5 grams per day after achieving a complete or partial remission initially. Doubling of serum creatinine was defined as a decrease in the estimated GFR by more than 50%. End-stage renal disease was defined as a GFR of less than 15 ml per minute, or a requirement for renal replacement therapy in the form of dialysis or transplant, and loss to follow-up and death. So this was the baseline characteristics of the 129 patients who were followed up over the period of 10 years. As you can see, they were mostly middle-aged, with the mean age being around 39 years. And there were more male predominance. In fact, 85 were male compared to 44 females. And the duration of illness mean duration after which they presented was around 3 to 4 months of starting of the illnesses they presented to our hospital. Mean follow-up was around 33 months. And out of which hypertensive were 30 patients, that is 23.3%, where mean creatinine at presentation was around 1.39 milligrams per deciliter. EGFR, they were actually having a slightly lower EGFR of 71. Mean EGFR was 71. Hemoglobin was 11.5, serum protein of 5, and they had a hypoalbuminemia. Mean hypoalbumin was 2.7, with the proteinuria being of nephrotic range, 4.93 grams. Cholesterol was also, as you can see, on the higher side. And this was the baseline characteristics with which our patients presented. So what was the clinical presentation of our study population? As you can see, majority of our cases, as also discussed in the baseline characteristics, presented with as nephrotic syndrome, with 96% being nephrotic, 18% presented as nephritic, and 6 people with 4.7% presented as an AKI, and 7%, that is 9 patients, presented as a rapidly progressive renal failure. So this was the comorbid illnesses in our study group. As you can see, majority of the population did not have any other comorbid illness, as is 60.5%. Rest around 17% had hypothyroid, and 10% had diabetes, 2.3% has coronary artery disease, and 1.6 had peripheral venous disease. Others being they had GERD, pulmonary TB, chronic filariasis, renal stone disease, asthma, and psoriasis, 1 each. So this was the renal biopsy characteristics that were seen in our study population. As you can see, majority of them presented as membranous only, that is 83% almost had a membranous presentation. 1.6%, that is 2 patients, presented with membranous with crescents, and 15.5% presented as membranous with FSGS, that may be secondary to proteinuria. Out of which IFTA, as you can see, majority of them had no IFTA at presentation, 55%, and 34 had IFTA, but it was less than 30%, whereas 10.9% had an IFTA more than 30. And Pla2R was seen Pla2R positive was seen only in 35.7% of the patients. 27.9 had an equivocal Pla2R, and 36.4% were Pla2R negative. So this, as I was telling you, was the treatment protocol that was used in our study. Majority of the patients in our study underwent 58 of them, that is 45%, underwent first cycle of modified Ponticelli. Rest, some people were treated conservatively with ACERB was given to all, but some people were just continued with this. Combination therapy, as described before, and I will be describing later, was given to 46 patients, that is 35.7. And only 7 of our population have been given de novo rituximab, that is without starting any of the Ponticelli or combination. After giving ACERB, they were directly started on rituximab. So as I was said, combination therapy, 99 of the patients were initiated initially on modified Ponticelli, and after 6 months, 58 achieved remission. So they were just continued on ACERBs. 41 people were started on combination therapy after 1 cycle of modified Ponticelli because they did not achieve remission, and 5 people were started on combination therapy de novo, that is without starting modified Ponticelli. They were directly given combination therapy. So the combination therapy was divided as follows. 14 patients who showed no response to 1 cycle of modified Ponticelli after waiting for 6 months were started on combination. 13 patients who continued to have partial response after 6 months observation post-modified Ponticelli first cycle were started on combination. 9 patients who showed a relapse at 6 to 12 months post-therapy of first cycle of modified Ponticelli, and 5 patients who developed a doubling of serum creatinine or ESKD. So the people who were started on combination after first cycle of modified Ponticelli, 26 patients were started on CNIs in the form of tacrolimus. 10 were given rituximab after 1 cycle of Ponticelli. 5 were given a second cycle of modified Ponticelli regimen, and 5 patients were started on de novo combination. That is, without giving Ponticelli, they were started initially only on de novo combination of either rituximab or CNI in 2 patients, and steroids and rituximab in 3 patients. So this was the complications of treatment that was seen in our population. As you can see, the majority of the patients did not suffer from any complications, that is 62.8%. And after that, the next most common complication was infection-related complication. I have not described it in detail. However, the infections included cellulitis in 11%, TB in 5, and upper and lower respiratory tract infections in 4 and 3 patients, and herpes zoster in 6 patients. So this was the second most, and after that we had steroid-related complications seen in our patients in the form of esophagitis, gastritis, pancreatitis, and Cushingoid feces. Cushingoid feces was the most common steroid-related complication seen, that is 9 patients. that 10.9% were suffering from Cushingoid facies. COVID was seen in 5 of our patients with 3.9%. Majority of the patients, however, as you can see, 62.8% did not suffer from any complications. So this was the overall response to various modalities of treatment as seen by our study. As you can see, 46.5% of the population achieved complete remission, and 23.3% achieved a partial remission. 10.9% underwent relapse, and 3.9% had doubling of serum creatinine. 2.3% had an end-stage renal disease requiring a renal replacement therapy, and 2 patients had a death. And the one patient who had death was because of COVID, and the other patient who died was having a sudden cardiac arrest in the form of acute myocardial infarction. And over the course of our study, 15 patients, that is 11.6%, were lost to follow-up. That is, they did not come to follow-up after 1 year. So I'm sorry for this busy slide. As you can see, this is the different outcomes based on each and every individual treatment. As you can see, the best treatment or the response was 7%. And after that, this was followed by a combination therapy that was 67.4%, Ponticelli that was 32.8%, and conservative treatment in 22.2%. However, as you can see, the number of the patients in rituximab was slightly on the lower side, so this may have actually given this very high response. Only 7 patients had rituximab therapy as compared to the rest. So, and you can see that relapse was seen majority in Ponticelli, 15.5%, as compared to other treatment. Doubling of serum creatinine also was seen majority majorly in Ponticelli. One of the reasons why we were having so many complications, because our treatment starting only is with Ponticelli. The patients who come to us are mostly referred to us, they're severe proteinuric, and they have already been given conservative treatment from outside. And so we start them on modified Ponticelli. Since out of 129, 99 patients were initially started on modified Ponticelli, and that can maybe explain the number of relapses and other complications that are seen with Ponticelli as compared to others. So this was a table which is showing what is the baseline characteristic and the association with the response. What are the characteristics that help in achieving remission or not? As you can see, we tried to see what characteristics can help in predicting response. And out of all the characteristics, one that is showing a significant response is with hypertension. That is, if the hypertension is present, there are more chances that the patient will not go into remission as compared to if a patient is non-hypertensive at presentation. Outside, other tests have also shown an association with serum PLA2R. However, we did not find any significant association with serum PLA2R, mainly being that less number of our patients had serum PLA2R as compared to tissue PLA2R. So another thing that we tried to find a correlation was between the histological features and their association. And we found that there was a significant association. That is, if there was more IFTA, there was more chances that the patient will not achieve remission, with the p-value being significant at 0.04. And this can obviously be explained that if there is more IFTA, that means that already there is damage to the kidney. So there are less chances that they will respond or have a response to the treatment. And there are more chances that they may go into doubling of serum creatinine or ESKD. So this was the table which is showing the type of treatment and its association with response or remission. As you can see that each and every of our treatment, this is a significant table with the p-value being less than 0.001. That means that each treatment was different, and the significance or the remission that was seen was definitely significant. And you can see that we had a very good complete plus partial remission with combination therapy, followed by rituximab therapy, followed by 1 cycle of Ponticelli, and followed by conservative. So this is just a very small, because I know of the time constraints, I won't go very into detail. We just tried to compare our study with other studies all over India and abroad. And we have seen that in our study, as compared to other studies, the modified Ponticelli did not give a very good response. Whereas, as you can see, the study from PGI, they had a good response. They had a complete remission of 58.8, whereas our study only had a complete remission of 32.8%. And another study that was also done in our institute some years back, before 2010, also showed a low complete remission, which was equivalent to our study of 27.5%. Other thing, we tried to see combination treatment because it was not done other places. Only other place that I found combination therapy that was used, except for our institute, was in PGI Chandigarh. And they also had a good response with combination therapy. After that is modified Ponticelli resistant cases that were treated with CNI rituximab. And you can see that both our study as well as their study is showing a very good response with 89.5%. And however, our study had less relapses compared to their study. And this was a study which used only de novo rituximab along with ACERBs for treatment of membranous nephropathy. And they also, as with our study, they also had a very good response of complete and partial remission being 64.9%. But our study is, however, better, but the number of population, ours is only 7 and theirs is 37. So maybe that is also affected. They had a high relapse rate, whereas we had only a relapse rate of 1 patient, 14.3%. So the conclusion from our study is that hypertension at presentation was a predictor for non-remission and relapse. Histological findings in the form of high IFTA, that is especially IFTA more than 30%, showed a correlation with remission. More the IFTA, less chances of attaining remission. De novo rituximab therapy was effective in achieving complete remission in 85.7% of our study population. And a combination therapy in the form of modified Ponticelli followed by either rituximab or CNIs had helped in achieving remission of 89.1% of in our study subjects. Limitation, obviously, it was an observational retrospective study. And the uniform treatment, because it was a clinician-based study, the non-uniform treatment methodology, especially for combination therapy, and the number of doses of rituximab was not uniform. Some places we used initially, especially we were using 375 milligram per meter square based on the CHOP regimen. And later, because the compliance was not good with that, we tried to change it to 1 gram every fortnightly. So the number of doses of rituximab used was also based on the clinical response, and CD1920 was not done in each case. So thank you everyone for your patience hearing.
Thank you very much again. You know, it's a wonderful clinical paper, a lot of pearls. I like the part about IFTA, and I think we as nephrologists and pathologists really look at the initial biopsy to predict how the patient's going to do. So at least in our group, if IFTA crosses 50 or 60%, we try not to overtreat them and, you know, just to use conservative therapy.
Yes, Shanilata, if you want to mention anything as we were guide for the study.
Yeah, I mean, we have a very good collection of 129 patients. I can see if you question the chat box as well. So, I mean, it's our protocol to start with the modified Ponticelli regimen. And if they don't respond, then only we go for a combination therapy. Initial years we used to go for a CNI, but off late. But after this rituximab has come into the picture, so we have started using the rituximab as a second line therapy. And only few patients recently we have started this only like, you know, the 1.5 years to 2 years we have started de novo rituximab, particularly in patients who are diabetic and you cannot tolerate steroids and then they may have a high chance of infection. Then we go for a rituximab because this is a cost constraint. It's a little costly and our patients can't afford. So that's why the group the numbers in that rituximab, de novo rituximab is very less. Only 7 patients we had. So of course we are continuing that study and probably next few years we'll add on a few more patients to that. And what we have realized is, of course, Ponticelli alone will not have a, you know, I mean, we have a 60% of the remission rates. If we add on, that increases to almost 90%. And now we have to see how, I mean, the most of the recent studies, they show that the rituximab, de novo we can use, and it's one of the, you know, the best choice for the membranous nephropathy, idiopathic membranous nephropathy. So we have to wait and see how our patient, you know, they respond to rituximab, and we can get away with the modified Ponticelli or the CNIs.
Thank you, Shanilata. Nice descriptive paper, and hope you would be able to showcase it in a right journal so more people can see it and learn it. So with that, we progress to the next study, which is done from my institute. I have not gone into detail of the methodology and the definition of CRPR. We followed the KDIGO 2012 guideline because of the time structure to showcase it in right perspective. I have gone little less in methodology and will ask my resident to start presentation. And we followed 2012 guideline up to 2019. After that, when Platoir based evaluations were available in our institute, we have started risk stratification based on Platoir as well and ascribing treatment that way. But that part of the study is not yet to be completed, analyzed. Up till 2021, the analysis part you will be seeing from 2016. Carry on, Tarak.
Dr. Tarak, please start sharing your slides.
Any difficulty, Dr. Tarak?
He's there, but he's on mute.
Tarak is there?
Yes, ma'am, he's there, but he's on
Yeah.
mute, ma'am.
I'll call him.
Yes, ma'am.
Yeah.
Am I audible?
Start. You are audible. Start sharing.
Okay. And the slides are visible?
No.
Yes, Tarak, you can go ahead.
Yes, ma'am. Yes, ma'am. Ma'am, now the slides are visible?
Yes.
Yes. Okay. Good evening and good morning, respected teachers and my seniors and my colleagues. Today, I am present myself, Dr. Tarak Chaudhary. I am presenting the learning management of membranous nephropathy, IPGMA data. The contributors are Dr. Abhinava Devnath, Anishnanda, Abhishek Kumar under the guidance of Dr. Urpita Rai Chaudhary. According to the published biopsy registry data of our institute, the incidence of idiopathic membranous nephropathy is 11% over 2 years, with nearly 1,000 native kidney biopsies done every year. Newly diagnosed membranous nephropathy patients were diagnosed every year is 50 to 55. The patients received treatment conservative or immunosuppressive according to the risk stratification as per the KDIGO 2012 guidelines. 30% of them, that is 12 to 18 new patients, achieved remission with conservative treatment, that is maximal antiproteinuria therapy, including ACE and ARB and other drugs. And the rest receives the immunosuppressive therapy in the form of either modified Ponticelli regimen, tacrolimus, or rituximab. In 2016 onwards, the rituximab had been available in our...
Dr. Tarak, sorry to disturb you. I think your screen is little out of our visual abilities. Can you please adjust the screen? Siddharth, can you help him out?
Okay.
Dr. Tarak, I think you had a larger screen size of PPT, I suppose. Rather than you going in screenshot mode, you enlarge your screen size. Sir, your PPT, sir, just at bottom right corner, there is a sign of plus and minus.
Yes.
Yeah, sir. Can you just reduce it to 100%? Yes, sir. Now you enter in slide share mode, sir. That will help, sir. Just beside that percentage segment, there is a slide share mode, sir.
Is it visible now?
No, again, sir, matter is going out of the stream. So you further reduce the size to 100, sir.
Actually, it is reduced to 40% now.
Okay, then
is it visible now?
It is visible, sir, but matters are out of the screen, sir. So for benefit of everybody, you can post this slide in the chat box. I will share it from here.
Okay. Ma'am,
It is out of screen, Tarak.
Siddharth, please help out. No, it looks little difficult for the audience to look at the slide.
Uh,
Or can we just go for the PowerPoint mode itself? That will be better rather than the slideshow mode.
yes, ma'am, we can go for PowerPoint mode. That
Yeah,
will be
please
better.
do
I
that.
think
Yes,
I think
please
that
do
would
that.
be
Tarak,
Dr.
Tarak,
Ah.
I think animations will not be available on PowerPoint without slideshow. So you may reduce your presentation to 60-70% if your 100% is not fitting the thing.
Ma'am, is it visible now?
No. Now visible, clearly,
Yes, yes, Dr. Tarak, now it is properly visible.
properly.
Okay. In 2016 onwards, rituximab had been available in our institute for membranous nephropathy patients, so we could analyze the outcome with different arms with minimum follow-up of 1 year post-recruitment in 2018, 19, and 21, gradually increasing the number of patients in each arm. Considerable relapse-related changes of therapy happened over time. The slides are moving.
yes.
Yes. In 2018, we have a small randomized control trial, including 11 patients in each arm, where we compare the rituximab versus modified Ponticelli regimen. And in 2019, we done a RCT, including 36 patients, 18 patients in each arm in tacrolimus versus rituximab arm. And in 2021, we have done a comparative analysis between the tacrolimus group, rituximab group, and modified Ponticelli group with a mean follow-up of 3 years. In all of these studies, the primary outcome is complete remission plus partial remission, and secondary outcomes are changes in the 24-hour urinary protein, that is the decline in 24-hour urinary protein, and recovery of serum albumin and adverse effects of different immunosuppressive therapy. In 2021 onwards, we have collected the extra data, that is the time to reach remission and proportion of relapse of all the cases. Now, the flow chart, which is showing the randomized control trial, which have received the rituximab versus modified Ponticelli. Here, total 54 patients are taken, and 32 are excluded from the study as they achieved remission, complete or partial, with conservative management. Another 5 patients were on tacrolimus, and the patients which received immunosuppressive therapy within 6 months are excluded from the study, and not willing for the study are number 4. So we have randomized 22 patients, and 11 patients are have taken modified Ponticelli, and 11 patients taken rituximab. And as it is a closed center study and no discontinued follow-up occurs, so all the patients are evaluated. In clinical outcome at various time points, it has been shown that the remission at 6 months were more in case of modified Ponticelli than rituximab at 6 months, but it is significantly more in case of modified Ponticelli than rituximab in 12 months. But the 6 months data is not statistically significant because of less number of patients. And the complete remission and partial remission also achieved is more in case of modified Ponticelli than rituximab regimen. And the number of relapse episode and no response episodes are also more in rituximab arm than modified Ponticelli arm. Now, remission rate at different time points. The orange line represents the modified Ponticelli, and the blue line represents, the blue bar represents the rituximab arm. Here it has been shown that at 6 months, the modified Ponticelli arm achieves remission at 70 to 80%, and in case of rituximab, it achieved around 60 to 65%, but at the end of 12 months, the modified Ponticelli achieved remission around 70 to 75%, but the rituximab arm maintained remission around 50 to 55%. And so 24-hour protein urinary protein analysis between the modified Ponticelli and rituximab showed that there is a decline in proteinuria, which is more in case of modified Ponticelli arm than the rituximab arm in both 6 months and 12 months. And the recovery of serum albumin is also significant in case of modified Ponticelli arm at 6 months and 12 months than the rituximab arm. Now, the next study, which is done in 2019, that is the tacrolimus versus rituximab study, which is done from February 2018 to January 2019, where 54 patients are screened and 12 were excluded from total 16 patients. 18 patients are excluded from the study because 12 achieved remission on conservative, and 4 received modified Ponticelli regimen, and 2 received immunosuppressant within 6 months, which are included as the exclusion criteria. And total 36 patients are randomized. 18 patients are included in the rituximab arm and 18 patients in the tacrolimus arm. All 36 patients completed treatments and 12 months of follow-up is done. All of them are considered for analysis. The blue bar diagram shows the rituximab and the red bar diagram shows the tacrolimus. It has been shown that at 6 and 12 months of treatments, the rituximab group, the decline in the 24-hour proteinuria is more in the tacrolimus group than the rituximab group in both 6 months and 12 months. And the recovery of serum albumin is almost equivalent in 6 months and 12 months in both the groups. So at the end of 12 months, 11% versus 22% patients were in complete remission, and 38% versus 44% in partial remission, and 16 versus 5.56% in relapse in rituximab and tacrolimus arm. But the p-value is not statistically significant. Now, the comparison between the tacrolimus arm and modified Ponticelli arm, IPGMR data 2021. In terms of primary outcome, there was no statistical difference in percentage of remission in each arm at 6 and 12 months. In terms of secondary outcome, there was statistical significant reduction in proteinuria and recovery of serum albumin in all the 3 arms over 6 and 12 months. However, there was no statistical significant difference in creatinine and eGFR over 6 to 12 months follow-up in terms of baseline. The creatinine and eGFR of tacrolimus and modified Ponticelli regimen, though there was a statistically significant difference, the difference was not significant at 6 and 12 months on follow-up due to the higher proportion of the AKI in the tacrolimus group. Now it is the Kaplan-Meier analysis showing an event analysis curve where remission is taken as an defined as an event. In this slide, the number of percentage the patient who are not in remission is taken as 1, and on subsequent slides the number of percentage are declining on treatment. So at the 0 point of time where we have initiated the treatment, where both the all the patients were in high disease activity and significant 24 hours urinary protein. So after treatment, the blue line represents the modified Ponticelli and the pink line represents the rituximab arm. It has been shown that in both the arms, the decline in at the end of the 6 months, the number of relapse, the number of persons in remission is more in case of modified Ponticelli arm than the rituximab arm, but at the end of 12 months, these are more or less equal in both the arms, and the p-value is not statistically significant. Now, time to remission analysis. It has been shown that the median time to remission and mean time to remission is less in case of tacrolimus and modified Ponticelli arm than the rituximab arm. And the median duration of remission is also more, and mean duration of remission is also more in tacrolimus and modified Ponticelli arm than the rituximab arm. The median duration of follow-up and mean duration of follow-up is usually done is more in case of rituximab as it shows the delayed response of anti-CD20 treatment because it takes some time to respond. And 15.5 months in done in case of tacrolimus followed by modified Ponticelli, and minimum time to remission achieved is usually takes in tacrolimus arm and modified Ponticelli arm, and rituximab usually takes slightly more time to take remission, and the maximum time to remission is usually achieved by rituximab arm. Now coming to the number of event analysis. It has been shown that in the RCT between the tacrolimus and modified Ponticelli arm, the side effects are more in case of modified Ponticelli arm. There is increased incidence of fungal infection, new onset diabetes mellitus, pneumonitis, leukopenia, and death. and the side effects are less in tacrolimus group, but the progressive renal failure is more in case of tacrolimus group than the modified Ponticelli group. So modified Ponticelli regimen, though have increased side effect, they are better renoprotective than the tacrolimus group. In rituximab versus modified Ponticelli arm, it has been shown that the progressive renal failure is more in case of rituximab arm than the modified Ponticelli arm. In the rituximab, among the 22 patients, 5 patients reached progressive renal failure, whereas in modified Ponticelli regimen, only 2 patients of 31 patients reached progressive renal failure. But the incidence of fungal different infection, that is fungal infection, new onset DM, pneumonitis, leukopenia, and death are slightly more in case of modified Ponticelli arm. So the side effect profile is better in case of rituximab arm, but the renal survival protection is better in case of modified Ponticelli regimen, though they have increased side effects. So the limitation of the study, as we have done only a single center study, we grew in numbers slowly over 5 years. We have taken a follow-up of 120 patients till 2021 and 79 in immunosuppressive arm, different type of immunosuppressive arm such as tacrolimus arm, rituximab arm, modified Ponticelli arm, and 40 were on conservative management. The resource availability issues which are present in low middle income countries such that the tissue plateau availability were not uniform. Quantitative serum plateau ELISA were available from 2019 onwards. So the extended study will analyze the relationship of plateau with outcome in different therapy arm. In 2020 onwards, we are giving dynamic risk assessment based therapy, including which included the plateau follow-up inclusion. Till March 2022, we are following up 150 patients, and the result and analysis of the study will be available in due course of time. So in conclusion, membranous nephropathy is a disease with high probability of relapse. We saw 3 different available effective therapies which may satisfy the need for use of alternative therapy. Therapy selection may give merit to the age of the patient, need for early remission induction, proteinuria, plateau level, EGFR at presentation, and prevailing comorbidities. Infections requiring hospitalization were common in both rituximab and modified Ponticelli regimen group, whereas new onset type 2 diabetes mellitus were seen in both modified Ponticelli and tacrolimus arm. So we must ensure that the dynamic risk assessment is required. Then the risk assessment at the baseline in determining the time to initiate therapy and the best regimen, whether it is conservative regimen or immunosuppressive regimen. Among the immunosuppressive regimen, whether is used modified Ponticelli, rituximab, or tacrolimus regimen. Thank you. Thank you, sir.
Professor Joy.
Yeah, so I think a nice paper. I think what is very interesting is the relapse rate, and it seems to be unusually high in this population. Now, what do you think that the therapy patients were able to complete therapy, the entire course of therapy, or were there interruptions?
Ma'am,
you're on mute, Arpita.
Shweta, you are on mute.
Yeah, actually, modified Ponticelli is little disturbed in COVID period. Otherwise, we have a separate GN clinic. So modified Ponticelli was going on with due care, every month follow-up. And I don't think people have missed therapy as the therapy cost was not high. And rituximab is observed therapy, which we have given in hospital, cost provided by hospital. There was minimum follow-up lost, so that was also, so whatever we have seen is real true relapse rate. For tacrolimus, there was little more continuation of the tacrolimus therapy, because during COVID period we couldn't stop them at 6 months or 8 months or 1 year. They have some people have some prolonged therapy, but other 2 arms are absolutely taken care as prescribed and as people have taken.
No, it just tells us that
can I share my experience with the relapses, madam?
Sure.
Yeah.
So what we have seen is patient, particularly on the CNI, I mean, after they complete their course of 6 months to 1 year, it's very difficult to withdraw them. These are the patients who relapse. And not what we have started doing now is we give them 1 gram stat of rituximab for them, so that it becomes easier for us to, wean off from the CNIs. So to consolidate the remission rate so that they don't relapse after that. So that we have seen that it works.
Okay. So this is a new idea. That is the thing I was talking of, the dynamic risk assessment, that we will keep on assessing that whether they are increasing in proteinuria, increasing in the plateau or decreasing in plateau, depending on that. Immunological remission, if it is there, we may wait more for clinical remission. If it is not there, we may add up another agent, what you are calling as combination therapy, Sharnalata. We may add up, before weaning from CNI, we may add up other rituximab or other therapies as appropriate for the patient. So with that, we may move on to our penultimate talk. If Padmini may take over and bring Joy to stage, a real joy for everyone.
Definitely. So coming to the penultimate session, a session we all have been eagerly waiting for, that is membranous nephropathy, past, present, and future. And who better to talk about it than Professor Dr. Jay Radhakrishnan, who actually doesn't require any introduction. He is the Director, Clinical Services, Nephrology Division, Columbia University, New York, Associate Editor of Kidney International, and the founding editor of Kidney International Reports, and the Global Educational Ambassador of International Society of Nephrology. Chairing the session are two stalwarts from the field of Indian nephrology, Dr. Manisha Sahai ma'am. She is the Professor and Head Department of Nephrology, Usmania Medical College, Hyderabad. She is also the Vice President of Indian Society of Nephrology, Editor of the Indian Journal of Transplantation, and member of the South Asian Regional Board of International Society of Nephrology. Co-chairing with her would be Professor Dr. Narayan Prasad. He's Professor and Head Department of Nephrology, SGPGI Lucknow. He's also the Honorary Secretary, Indian Society of Nephrology, Deputy Chair, South Asian Regional Board, International Society of Nephrology. So my humble request to Dr. Manisha ma'am to take us through this session. Thank you.
Yeah, thank you so much for this opportunity. And as Arpita rightly said, joy to listen to Dr. Jay Radhakrishna, excellent speaker, and the best person to talk about membranous nephropathy. We are eagerly looking forward to his talk, the past, present, and future. So let us see what he tells us, and we can have a fruitful discussion later on. Honored to be here, Dr. Joy. It's always a pleasure listening to you.
Thank you very much for this invitation, and it's very humbling to see such excellent work being done and such interest in patient care and successful patient care. I think it's a real honor to be here. Thank you very much. So today's topic was on membranous nephropathy, past, present, and future. I'll try to compress this into a clinically meaningful conversation rather than sort of a didactic thing. I'd like to acknowledge two entities. One is the Glomerulus Center that I work at Columbia University. There are 5 of us who predominantly work in this area, both in terms of research, teaching, and patient care. And then I was fortunate to be part of both KDIGO guidelines. So I'd like to sort of at least highlight some of the guidelines that are relevant to membranous nephropathy in the course of this discussion. So these are my disclosures. I work quite closely with pharma companies that are actually bringing new products in the pipeline. And so it's nice to guide them through the design of clinical trials. And as you can see, there are a lot of companies that are going to come out with products for membranous nephropathy in the near future. So the past is very short, actually. So back in 1946 was the first description of membranous nephropathy. It was well known that the patients had nephrotic syndrome, but pathology became sort of a field in and of itself in the 50s. But this was the first description that some people with nephrotic syndrome had thickened membranes. But the pivotal role of what this is about was made by Heyman in 59, and we call this the Heyman nephritis model. Even now, and it's a very well-established animal model for eliciting membranous nephropathy. So you take a rat, you basically grind it up the kidneys, and you get this basement membrane antiserum. And then you inject this serum into a normal rat, and then you see what happens in the rat, and you'll find nephrotic syndrome happening quite early, actually. And the second key observation was, what are these antigens? So in a rat, at least, it turns out to be this thing called GP330. And this was made by Donjo Karashaki from Austria back in '87. So after the discovery that there were these antigens, megalin actually, in the podocyte, the rush to discover these antigens, was huge. And the person who succeeded was David Salant and Larry Beck. In 2009, discovered this pivotal role of PLA2R antibody in causing a majority of patients with membranous nephropathy. So that is the past, and it's compressed. There were a lot of other events which I won't talk about. But coming to the present, I think the key is to learn that pathophysiologically, we are in a very good place in understanding why this disease entity happens. So we now know that Dr. Sethi and others are actually just, they have a cottage industry discovering antigens almost every, I'm going to say a year there are one or two new antigens coming out. So you can see across the board, and I won't go into all these details because Geetika had nicely mentioned this already. But the key part here is that we don't know what to do with these antigens on the right compared to what we know about PLA2R on the left. The other aspect of disease predisposition is in doing this GWAS, and this GWAS study was very well done. And they found that there were two SNPs, one relating to the HLA-DQ-A1 complex, and the second SNP was related to the PLA2R protein itself. So if you look at control patients which do not have either of these SNPs, as you become a heterozygote and then a homozygote, your odds ratio goes up, both for the PLA2R SNP as well as for the HLA-DQ-A1 SNP, such that in the patients with the highest risk, which is a combination of two homozygotic genotypes, you can see that the odds ratio is as high as 80. So this is a nice demonstration that you have an abnormal protein and an abnormal immune response to the protein which work in concert to produce the entity called membranous nephropathy. So then there's this entity called segmental membranous, and you might see a report from a pathologist saying that on electron microscopy, if it's done, you may not see a complete deposition of these antigens in the circumference of the GBM. So these are defined by our group. This is a study that Dr. Kodose from our group published in Kidney International 2 years ago. So this is 25 to 75% of the GBM has deposits, not 75 to 100, which is typical of most patients with membranous nephropathy. So are these patients different from the normal pattern of membranous? And here you see that there are two differences, that NEL1 is seen in 30%, and most of them are very early stage. And the second observation is that the PLA2R and other classic antigens were negative in all these cases evaluated. And the third was that if you look at their clinical course, they actually do quite well. So the majority had complete or partial remission, even without the need for immunosuppressive therapy. So when you see segmental membranous in your biopsy, you can tell the patient that, we'll maybe observe you and not treat you aggressively, because there's a good chance that you might just get better on your own. And then this other entity called membranous-like glomerulopathy with masked IgG kappa deposits. And why was this discovered? Because nowadays, when you do immunofluorescence, if you find a negative staining, we do what's called pronase staining. So most pathologists around the world are doing this to see if there are hidden epitopes that come up. So it turns out with classical membranous nephropathy, which you can see in light microscopy, initially negative becomes positive. And these are typically patients who have no underlying lymphoproliferative disorder. And in fact, they have a high chance of getting either an autoimmune disease or positive autoimmune serologies, typically an ANA with or without a double-stranded DNA, without a classic lupus based on criteria. So one thing that's been just discovered is that if you look at these patients with this membranous-like glomerulopathy with masked IgG kappa, you see that the serum amyloid P component is a specific and sensitive marker of this disease, just like DNA JB9 is a marker for fibrillary. So this is now being widely recognized as being a component of this study. So if you find this in your patients, you could ask for the staining if it's available. And this is one way to sort of say that this separates this group of patients from the usual patients with membranous nephropathy, in the sense that it's monotypic and it has this marker SAP. So the proposition by Chris Larson and company was to call this a new name. It's called monotypic SAP-associated glomerulopathy, rather than calling it, the masked membranous. So I'd like to spend some time in PLA2R because this has now become standardized and it's available worldwide, both in the biopsy as well as you can measure it in the serum. So the most important point is that you need to know what test your lab is doing. So Western blot, which is the research test, is not done commercially. So there are two commercial tests available. One is called the immunofluorescence test, and the second is the ELISA. So the immunofluorescence is more sensitive than the ELISA, but the problem is that many labs do not report a titer. They can say negative or positive, or they can do plus minus, or some serial dilutions, whereas the ELISA has a nice numerical value. And for the most part, especially for clinical trials, we are using ELISA. And if possible, we'd like to use this test in the clinic because it seems to be a little easier to translate into how the patient's doing compared to the IFT, although which is a good test, but following titers is a little challenging when you use an immunofluorescence test. So the first question always comes is that I have a patient with nephrotic syndrome and the PLA2R is positive. Can I avoid a kidney biopsy? And it turns out the answer is yes. So if you are very selective in these patients, so you need to have a eGFR above 60. You need to exclude all the patients who are have a secondary problem. So for example, if you're Hep B positive or ANA positive, or if you have underlying diabetes mellitus, we don't like to do this in pediatrics, definitely not in kidney transplants. So if you rule out all these conditions and your eGFR is above 60, your chance of getting membranous is over 95%. So in the KDIGO, what we said was, if your PLA2R is present and you have normal kidney function, you've never seen immunosuppressive therapy, you can assume it's going to be membranous, and there is no need for a kidney biopsy. In all other patients, if you've seen immunosuppression or there's something unusual, saying a rapid decrease in GFR, your serological tests are positive, especially ANAs, which means lupus membranous nephropathy is likely. Or if you have received immunosuppression and have not responded, especially if your kidney function is declining. And we had mentioned a couple of patients from Arpita's group who had crescentic membranous, crescentic lesions associated with membranous. So those patients definitely need a kidney biopsy. So can we predict outcomes based on your PLA2 titer at the time of biopsy? So this is the ELISA test, and you can see there are three tertiles: lowest, middle, and highest. And if you see, what happens is that spontaneous remission is unlikely when you look at the higher titer antibodies in the ELISA test. And it's the same story if you have very high titers in the IFT test. Your chance of remission is very low, and such patients may not need a prolonged course of observation to see if they go into spontaneous remission, especially if they're heavily nephrotic and especially if kidney function is impaired at the time of biopsy. So you can go straight into immunosuppression with a high titer and with risk factors that are present. And we'll encapsulate this in the KDIGO guideline slide, which I'll show you. How about remission status based on the PLA2R? You can see that your risk is again low with these titers. This is another study that confirmed the same findings. And then your relapse rate is high if you're PLA2R positive at the end of your immunosuppression. So it's very, very important now, not just to follow proteinuria, but to keep looking at the PLA2R status. And if you are persistently positive, and we'll talk about at what milestone should you reevaluate to see if therapy needs to be changed, you need a negative PLA2R titer before you can say the patient's going into clinical remission. And then finally, progression also can be somewhat predicted by your titer. So you can see the high, medium, and low corresponds to the proteinuria as being much higher, and the chance of going into the into a doubling of creatinine or 40% increase in creatinine is much higher when you look at people with very high titers. So these patients should be treated aggressively and early to prevent kidney function deterioration during the course of observation. So there are studies that, one study at least in KI reports, I accepted this paper, showing that just one titer is maybe not that meaningful. And you can see that in the Netherlands, looking at patients who went to remission versus not, or actually progressed, there was not a big difference in the PLA2 titers. So what they're saying basically is don't look at one titer, look at the baseline and see what happens to these titers, either over the observation or when you're treating these patients, to get a better idea of how patients will do over time. So the biggest part is, like, I have the PLA2 titer here in front of me. I made the diagnosis. Now, can I make a difference in the type and how soon to treat? And here there are two concepts, and Geetika just mentioned this very briefly, that there is a concept of immunological remission, where the PLA2 titer goes from positive to negative. And then there's a concept of clinical remission, where the proteinuria goes from nephrotic to subnephrotic, which is partial, or under 500 milligrams, which is complete remission. And which drug is likely going to be helpful? Does PLA2 titers tell you about this? So I just want to show you one study, the GEM-RETUX study, and this was a 6-month study. And they showed that there was no difference in proteinuria at the end of 6 months when you compare rituximab versus conservative therapy, which is blood pressure control using the maximally tolerated dose of RAS inhibitors. There was a difference in serum albumin, however, but very importantly, that PLA2 titers dropped dramatically in the rituximab group and did not change much in the conservative arm, despite the lack of a difference in proteinuria. So the important point is they did extend the study to 17 months. And at 17 months, you can see very clearly that your remission rates are much higher in the group that received rituximab compared to the conservative arm. So this comes, that same graph which Geetika showed, I want to show again, is that we'd like to look at PLA2 titers as an endpoint of your treatment, because that tells you that the immunological process has been switched off. And it takes several months to even a year or two longer for the proteinuria to go into complete or partial remission. And again, when you go into remission and your PLA2 titers go from negative to positive, this will precede the clinical relapse, which is proteinuria, by several months. So these patients should be followed up very carefully when PLA2 titers have disappeared and then have become positive during the follow-up phase. And I won't go into the positive negative slide, but this was discussed extensively by Geetika in her talk. So the question is choice of therapy. And this is the famous MENTOR study that looked at cyclosporin versus rituximab, and they followed the patients over a course of 12 months. And you can see that the incidence of partial or complete remission, about 70%, was not different between cyclosporin and rituximab. You could see that early on, at 6 months, there was a difference in that patients on cyclosporin did a little better. But the important point is, after you stop therapy, after the 12-month time, there was a clear difference in how patients either remained or did not remain in remission. And we saw this with the previous two talks, that if you use a CNI, it's difficult to get them off a CNI in the setting of partial or complete remission with cyclosporin. And it's the remission is much more durable with rituximab. So based on this study, there was a hidden in the supplements was a very interesting point, is that for rituximab treated patients, your baseline PLA2R levels in those who had a less than a 25% decrease in proteinuria was much higher, okay, versus those who had a more than 25% decrease in proteinuria. So your baseline rituximab also tells you how you're going to do, your baseline PLA2R tells you how you will do with rituximab in terms of your proteinuria reduction. So the question then comes is, are there any data on the type of the therapy versus response rates? So you can see on the top is proteinuria and the bottom is the ELISA PLA2R. And you can see all three agents, rituximab, alkylating agents, and a CNI, had similar rates of reduction of PLA2R, But you can see there's a slight difference in the proteinuria reduction rates with these drugs. It is much less with rituximab early on, but eventually at 9 and 12 months, the difference narrowed. So there's a thought that maybe a CNI is not as effective as rituximab or cyclophosphamide in reducing period-2 titers, which is not true. The added advantage of using a CNI is that you get direct effects on proteinuria reduction early on in the treatment phase, compared to say rituximab, which takes much longer to work. So then I come to the KDIGO guidelines. We'll put all this in and say that how do we treat patients who are sitting in front of us? So we should not forget that blood pressure goal is extremely important. If your blood pressure is not controlled, especially with proteinuria, it'll take much longer for patients to go into remission. And in fact, you may magnify the rate of progression of kidney disease in untreated patients or patients who are suboptimally managed. So ideal is 130/80, but there's a move towards reducing it even lower, 125/75. And this can be done with a variety of agents, the most important being a RAS inhibitor. So when you get membranous nephropathy, it's important to screen for malignancies, even if you're PLA2R positive, because the risk of the odds ratio of malignancy is much higher, even in PLA2R, versus the normal population. Most patients will get an ultrasound of the kidneys to get kidney size, and it's not recommended, but you could look for renal vein thrombosis. And then infections, very important. We look for chest X-ray because sarcoid is a known, even in PLA2R positive, is associated with membranous nephropathy. Run the medication list and look for evidence of lupus by using a rheumatology panel. And then we do a full exam for coexisting conditions. So this slide is very important, and it relates to the risk. And there was a couple of comments in chat, so I would like to encourage you to look very carefully at this risk stratification in membranous nephropathy. So the low risk is very easy. If you're subnephrotic and serum albumin is above 3 or 30 grams per liter, you're considered low risk when a GFR is normal. Or if you've seen patients who are not at low risk, but over time, say you're at moderate risk with more than 3.5 grams, but your proteinuria comes down with 6 months of conservative therapy, then you move from moderate to the low risk category. And these patients, as you'll see, don't need to treat with immunosuppression. In contrast, the very high-risk patient has a life-threatening nephrotic syndrome complication, for example, a pulmonary embolism, or there is a rapid worsening kidney function that you cannot explain, say, with a drug-induced side effect or a hemodynamic reason. So these people are at very high risk, and they have to be put into a bucket of aggressive early therapy with immunosuppression. And then we look at moderate and high risk. Moderate risk is those people who remain nephrotic after 6 months of conservative therapy and do not have any of this high risk criteria. So high risk criteria is very important. You have impaired kidney function or proteinuria more than 8 grams for 6 months. So that's one group. The second group is you have a normal GFR, but you have not decreased your proteinuria to subnephrotic levels after 6 months of conservative therapy, plus low serum albumin, a high level of PLA2R. And this is very arbitrary. We had to use a cutoff, and we thought 50 was a reasonable cutoff based on studies. And the last few tests are relating to tubular damage. It's not available commercially in many countries. We don't use this either, nor do we use the selectivity index in terms of IgG versus albumin. So the bottom line here is that impaired kidney function and level of proteinuria more than 8 grams more than 6 months, or people who have nephrotic range proteinuria and clinically less than 25 grams for albumin and higher level of PLA2R. So this puts people at a higher risk. So when we look at where we are now in terms of treatment, you can see that there's been a whole host of studies, starting with the Ponticelli that you heard. There was an attempt at using mycophenolic acid. It does work sometimes. It certainly works in lupus membranous nephropathy. But right now we're looking at rituximab, we're looking at cyclosporin, and we're looking at the classic Ponticelli regimen as the 3 arms of therapy that we need to choose between. So we come back to our risk stratification, low through very high risk. Very high risk, you don't need to think further. Go straight for an alkylating agent. Usually it's cyclophosphamide and steroids, and people have used variations of the Ponticelli regimen, and this is has been shown to be the most effective in this very high group. In the low risk, again, do not treat. In the moderate risk, you can wait for 6 months for sure. And if people respond and go into the low risk group, there's no need for further therapy. Or if there's symptomatic nephrotic syndrome, you can choose between rituximab or between a CNI and low dose corticosteroids. There's no difference in either of these two. As you saw, that they do both have a fairly decent rate of remission inducing chances. And the only problem with CNIs is that you are going to experience a higher relapse rate. But the high risk is a little tricky. Here, in the absence of any of the very high risk criteria, either rituximab or cyclophosphamide corticosteroids, Ponticelli, or a CNI and rituximab. Now, this is a little tricky, and I'll tell you why in a minute. Because if your patient has worsening kidney function, you certainly don't want to use a calcineurin inhibitor. So if your patient is a high risk with intact kidney function, this is just fine. And Dr. Swarnalatha had mentioned that she uses this technique to get patients off of a calcineurin inhibitor by adding on rituximab at the end of a certain time interval. So the other important part of managing patients is one needs to look at serial PLA2R PLA2R titers. And then based on the PLA2R titers, you can make treatment decisions to when you see that the titers are either disappearing or not disappearing. So if you disappear at 3 to 6 month intervals, and that is the approximate time interval that we recommend checking these titers. So you can do it a little earlier if your patient is at high risk, right, or a very high level of PLA2R. In these patients, I usually do it monthly because by month 3, I need to be sure that these titers are dropping. Otherwise, I will change therapy. So generally at 3 to 6 months, you see what happens. If it disappears completely, the patient is going to immunological remission. And despite being nephrotic, there is no need to add additional therapy. However, if your PLA2R titers are intact and not disappearing or in fact worsening, you need to see if the patient should change therapy at this 3 to 6 month interval period, especially in the patients who have a very high titer or who are in the high risk category. So here are the possibilities. If you're use either of the 3 therapies and your PLA2R turns absent or negative from positive at 6 months, if you're on rituximab, do not give more. If you're using Ponticelli, you can stop right there. The moment your PLA2R titer stops, you don't have to complete the full course. And then if you're taking a CNI and prednisone, do not stop, but start tapering and see what happens. It may take several months to get off the CNIs. But at the same time, one needs to keep looking at the PLA2 titers, which have turned negative, to see if they turn positive, because your relapse rates are going to be very high at that point. If your PLA2R is present, and if you were originally on rituximab, keep going, add more courses until the PLA2R is negative. If you had previously received cyclophosphamide and steroids, at this point, you can switch to rituximab. And if you're on a CNI, you can either add a rituximab to the CNI, as Dr. Swarnalatha was doing, or you can switch to a Ponticelli regimen at this point. And then finally, you have PLA2Rs present, but it's decreasing or it's gone to low levels. You would still continue with the rituximab because you want them to get into a negative situation before saying that they're going into immunological remission. If you have given cyclophosphamide, there is a legacy effect which can persist for several months. So here you can watch and see if they, because you don't want to keep exposing your patients to unnecessary cyclophosphamide. If you're in a CNI and prednisone, you can keep the drug on and keep looking at these titers and clinical situation after another 6 months. So this encapsulates very nicely what do I do with my patient based on PLA2R titers and the initial therapy, whether it's rituximab, your Ponticelli, or a CNI. And then patients who relapse after successful therapy, if it's rituximab, it's okay to give rituximab again. If it's CNI, this is the patient, again, you'd like to use rituximab, and you can add it on to CNIs, especially as you taper the CNIs, the patient's proteinuria gets worse and in the presence of a positive antibody. And if you've received cyclophosphamide and steroids, some people would continue for longer, but most of us would switch to rituximab with or without a CNI. And then finally, resistant disease, which is about 20 to 30% will not respond to your initial therapy. So the most important thing is that no matter what you're receiving, if your GFR is decreasing while on therapy, and if you've not seen Ponticelli or cyclophosphamide before, this is the time to start, okay, no matter what you've seen before. And if you're already on cyclophosphamide and GFR is getting worse, keep this on for a while longer. For every other patient where GFR is stable, we can go from therapy 1 to the other 2 therapies. And that's really the essence of what we do with resistant disease. If everything fails, then we have clinical trials that are looking at other drugs. We use ACTH quite commonly in this situation. And in some patients, it seems to stabilize kidney function. So combination therapies, we'll discuss this in some detail. And you can see this is a pilot study. And usually by 3 months, it's rare to find people going into partial remission with monotherapy. But combining rituximab and cyclosporin, actually, there was in this pilot study by the NIH, there was a very rapid reduction of proteinuria in this uncontrolled study looking at a group of patients with membranous nephropathy on the combination. The Starman trial also illustrates very nicely what do we do with patients when you compare Ponticelli with tacrolimus alone and see what happens over time, right? So if you look at the depletion of PLA2R antibodies with sequential therapies, less people have it. So initially on tacrolimus, only 45% depleted their PLA2R versus a much higher rate, as we saw in the presentation from Dr. Arpita's group, that you deplete PLA2R much more vigorously with Ponticelli regimen. And at 6 months, again, much higher response rate with PLA2R compared to only 70% with tacrolimus. But what they did in this study was, at the end of 6 months, if patients are not in remission, immunological or complete remission, at this point, you can give rituximab. And that way, you don't need to give rituximab. It's a very expensive drug, as you know, especially including in the US, because we cannot get it approved very easily in the insurance companies because it is not FDA approved. So this is a decent way to see if patients will go into immunological remission in 6 months. And if they don't, then you add on the rituximab at 6 months. And you can see that your relapse rate's a little higher, not very much, compared to cyclical methylprednisolone and cyclophosphamide. So another way you can treat your patients is start with tacrolimus, and then if they're not going to remission, you can add on rituximab at the end of 6 months. And you can see adverse events were equal in both groups. And then can you compare head-to-head the cyclophosphamide with rituximab? And this is a small study from Italy. They had 74 patients, approximately 37 in each group, randomized to Ponticelli versus rituximab. They had just received 2 doses. You can see the complete remission rates were small, less than 50% eventually. And the remission was earlier with the cyclophosphamide compared to rituximab, but eventually they were similar. And when you look at the total remission rates, again, it is about 75% and no difference in the 2 groups. So it seems that despite the slight change in earlier remission rates, eventually both the groups were similar in their rates of complete and partial remission. So again, tells you that there is nothing magical about rituximab compared to traditional therapies of Ponticelli. And the adverse events rates you might think is worse with cyclophosphamide was not the case in this study. So one way that we approach patients is to look at the PLA2R, and based on the PLA2R, you can give additional doses. And that's what we are saying in the KDIGO, is that most of these studies that we mentioned do not give a PLA2R based re-dose with rituximab. And you can see that the remission rates by using just the 2 standard doses at the beginning is between 30 and 60%, okay, in this group early on. And clinical remission rates similarly were not very high, and very, very low complete remission rates. But if you look at PLA2R and redose them based on the presence of PLA2R, you can see that the immunological remission rates goes up very high to 90, and your complete remission also is much higher, as is partial remission, compared to your single 2-dose and let's wait and see what happens approach that used to be the case in the studies that have been done so far, mainly because they had not used PLA2R as part of the decision-making process. But now we know it's very important, and we should use PLA2R when making clinical decisions. So I'll end with the future. Future is very short, luckily. So what we know about membranous nephropathy is very beautifully that it's an antibody-mediated disease. So your B cell pathway from pro-B to immature, mature, activated B and plasma cells, this inhibition of this pathway is crucial to inhibiting the pathogenesis of membranous nephropathy. So we know all about CD20, which is present in most B cells, beginning with the pre-B cell to the activated B cell. So knocking down CD20 and thereby depleting B cells is definitely works, as we saw. The other part is that once you deplete B cells, there are memory cells, and these become activated in the presence of these what we call survival factors. One example is BLIS, and there are several receptors for this, BAF, BCMA, or TACI. And there are these antibodies called belimumab, used in transplantation very commonly nowadays to prevent rejection. But in lupus, this is now FDA approved, belimumab. So the idea is that can we utilize this BLIS pathway inhibition to enhance the or prevent relapse rates in membranous nephropathy. And on the right side, we need plasma cells to make the antibody. So there are two targets. One is a CD38, and there are specific monoclonal antibodies like daratumumab. And there are proteasome inhibitors that are also responsible for plasma cell function that you can inhibit, and then that can lead to hopefully improved rates of remission. So just to give an example, we are doing this reboot study. This is sponsored by the NIH. And here all patients get belimumab in combination with rituximab given at weeks 4 and 6. And then seeing if that makes a difference based on just rituximab alone. I'm sorry, based on compared to tacrolimus alone. Then the other pathway that is important is complement. So when you see these IgG4, which is a complement activating immunoglobulin, it leads to activation of complements through the lectin pathway, as was mentioned. And you have specific receptors for C3A and C5A, which are the activated parts of this complement pathway. And then you get assembly of the membrane attack complex on the podocyte, and that both through internal activation of certain proteases will disrupt proteins that are responsible for podocyte function. So inhibiting complement pathway may have a role. And in fact, there is one inhibitor called iptacopan that is a factor B inhibitor. Factor B is an important part of your C3 convertase. So if you block this, you block C3 convertase, but it turns out that your C5A is somewhat inhibited, but not completely inhibited. So your risk of infection hopefully is not as much as with the C5A inhibitor like eculizumab. So this study is being done right now. So I'd like to end by just saying that, we have come a long way in membranous nephropathy, both in understanding the pathogenesis, and which has led to the discovery of diagnostic molecules like the PLA2R antibody. And the use of all these technologies and antibodies has really changed the face of membranous nephropathy. And I thank you for coming to this talk, and I really enjoyed hanging out with you guys. And hopefully there are some questions.
So thank you, Dr. Jay. That was an excellent presentation. You have highlighted all the practical points beautifully and the practical approaches as well. So very practical points. Thank you for that. So just one question from my side. What about the role of SGLT2 inhibitors? We hear so much about them in IgA nephropathy, and in DAPA-CKD also. We had, I think, around 2% or 1% patients of membranous nephropathy as well, where there was reduction in proteinuria and stabilization of GFR. So do you think, that's a hype in membranous nephropathy? IgA, we are now hearing that it's the standard of care. It's soon to become the standard of care with the RAS blockade. So what do you see would their role be in membranous nephropathy?
So I look at, this is a great question, Manisha. So the way I look at SGLT inhibitors in the management of any glomerular disease is whether or not the patient's going to remission early, or is this going to be a lifelong problem or a 1 or 2 decade problem? Because the benefit of SGLT2 inhibitors is not early. It's more of a delayed, maybe months to years after starting it in terms of reduction of fibrosis. And early on, you may get some reduction in proteinuria, but it's by no means a powerful proteinuria reducing agent, with the probable exception of IgA nephropathy, which unfortunately, in the trial, it was a mishmash of patients with IgA nephropathy. It was not de novo. So I think we need to study this a little more. Clearly, if your patient has CKD that is progressing in the presence of proteinuria, I would use it, and I'm using it all the time in any and all glomerular disease with that profile. But if someone has FSGS and is going to remission and kidney function is stable, this is an expensive drug even now, and it's not completely bereft of side effects. So when you add on SGLT2 to a RAS inhibition, you may see a drop in GFR, a little more than each alone. And then if the patient has compromised kidney function and you lose, say, 10 to 12%, which is usually with the SGLT2s, you don't want to sort of change the, the equilibrium of such patients. So use it with a lot of thought, not in every patient, but in selected patients.
Okay, thank you. And just another question about what do you do for those patients who have who become plateau negative after immunosuppression, but proteinuria persists. We have some patients where the proteinuria has persisted more than a year after the plateau became negative. So what would you do for such patients?
So that's the key point of this talk, is that don't touch them with immunosuppression. You can put them, if they're on a CNI, I would just continue them on. I would not take that off, because that has direct effects on the podocyte outside of the immunological effects. And just keep going. Over time, most of these patients will go subnephrotic. They may not ever become less than 200 or 500 milligrams, but just the fact that they've dropped from over 3 grams to under 3 grams and 50% reduction, that itself puts them into a good category, and there's no need for further immunosuppression in these patients.
Okay.
With the exception of a CNI. Yes.
Okay. Yeah, Arpita, were you saying something?
Yeah. I was just sharing one response to your question, that in our OPD, I think 4 or 5 membranous patients were given SGLT2I, and our experience is not a very happy experience.
Yeah.
We looked at the GFR, which fallen, we withdrew, and the GFR came back. And I think even if it is, as Joy was telling, that even if it is appropriate for IgA nephropathy, probably it will not suit best for membranous from those 5 patients. And what my question to Joy is, why we are so restrictive about duration of CNI in membranous? Why we can't think of a little longer duration of CNI? What does it harm? In pediatric SDNS and SRNS study, in our transplant group, we have looked at tacrolimus use for longer, which hadn't given that bad result to us. So why we are so much restrictive about the duration? What happens if we can prolong with looking at the plateau or fall, that if we can induce an immunological remission with a little low cost drug for longer time? Number one. And the second question is about what do you feel about this about Rituxan use as primary in an LMIC country like us, where we have looked at our population too, where high risk responded well to cyclo, and the low risk we may combine with TAC followed by Ritux or cyclo as it is appropriate, as we were discussing the risk issues. Why can't we go for that?
No, so I'll answer the second question first, and it's completely appropriate not to use rituximab if your patient can't afford it. You should not force the drug onto them. Cyclophosphamide is equally safe, it's inexpensive, and it works probably much better in getting them into remission. So I think it's an underused drug. The only problem is that the steroids are a problem, right? So giving high doses of steroids on the off month and continuing the low dose steroids on the on month does impose a lot of steroid-induced side effects. So what I've done in my own patients is I've actually used cyclophosphamide monotherapy in such patients, and I don't believe steroids has a big role in membranous nephropathy in and of itself. It may have an augmented role in improving remission rates, but I don't think it's worth the side effects in terms of combining it with cyclophosphamide. So people whom I've given cyclophosphamide as monotherapy, you can actually extend it to maybe 3 to 6 months. your response rates are quite good with just monotherapy and adjunctive therapy. And again, I completely agree. You don't have to force rituximab on all patients because of the, it's easy to give and it's 2 doses and we're all done and that kind of thing. But it's extremely expensive, and you may
that
argue
probably
that,
doesn't happen too. It comes as relapse, as you were telling me.
No,
we
absolutely.
are
So it's
seeing
not,
relapses too in Ritux arm as well, and that's
totally
not infrequent.
correct. So I kind of like the combination approach that I'm using more and more of that. If patients are heavily nephrotic, they have 10, 12, 15 grams, and the kidney function is relatively intact, I use a low dose of tacrolimus with rituximab or even cyclophosphamide in such patients to get them into remission a little quicker.
And one thing is the EGFR. Sometimes we get a compromised EGFR at presentation, which is pre-renal AKI, not the true EGFR loss. And as soon as we start repleting albumin and using diuretic and albumin in appropriate combination, we find an improvement of GFR even without addition of immunosuppression. Probably those are high proteinuric patients and going into nephrotic AKI, as we see in pre-renal, and EGFR appreciation to take them in a risk factor analysis, as you have done in Toronto risk factor group, should be done after correcting this pre-renal AKI. What do you?
Although I must say that so such patients, even if you correct, the pre-renal AKI is easy. You can try the albumin and all those things, but even then, of these patients, there's a significant number who come in with the creatinine of 1.2, 1.5. And these patients are really at very high risk of progression, despite correction and everything. So remember, your AKI is a marker of severe interstitial inflammation, which is a downstream effect of proteinuria, right? And these patients have to be, you cannot wait for 6 months in these patients. You have to treat right away. And then, if you wait 6 months, the fibrosis is basically progressing, right? So this group is what I call the very high risk group here.
What's your experience regarding tacrolimus versus cyclosporin? Arpita's group, they have been using tacrolimus. We have been using tacrolimus as well because it's easier available to us as a part of transplant program in the setting, and our results have not been that bad. In those patients who relapse after completing the course of TAC, we give a rituximab. That's what we do because that's the policy most favorable to us. Economy wise. So what's your experience there?
No, the only reason why I use TAC is, it's got less cosmetic effects. And I think the PK is a little more predictable, and there may be more avid calcineurin ligation. So I think it's a easier pharmacokinetic wise drug to use compared to cyclosporin. It's just a personal thing. There are no head-to-head trials, but it seems to be easier. But of course, if your patient's pre-diabetic, you'd not use TAC, you use cyclosporin.
And a longer duration of CNI?
Yeah, you can go long. I think you just have to watch your, kidney function. But what I would say is the moment you get into partial remission, it's best to start tapering doses. I would not go for definitely more than a year and a half is probably my upper limit on a CNI.
How long do you follow up your patients with plateau or antibody once they have achieved remission completely?
So my protocol is to monitor them for every 3 months until they go into full remission.
After that, once they go into full remission?
Yeah, then I give them a home dipstick and have them come back if the dipstick turns positive, or if they start getting symptoms of. So there's no need to per se follow them. Although you might argue that if your PLA2R is turning positive in such patients, then bring them back for more close follow. But I think you would not, automatically start them on therapy if your PLA2R is positive and there's no heavy proteinuria. Right?
So have you had any late relapses? Like we had a couple of cases where after 10 years, they have relapsed.
Yeah, we actually published on this. We look at AJKD. We published on these late relapses, and they're no different actually from the usual patients.
We have some audience question also. Somebody
bring them to stage, Padmini, the audience questions, so that we can answer.
Dr. Atanupal is asking, is there any role of finerenone?
Oh yeah, very good question. So finerenone is not yet approved for outside diabetic nephropathy, and it's a very expensive medicine. But you can certainly use spironolactone and eplerenone as proteinuria reduction strategies. I must say that in my personal experience, it doesn't add a lot to ARBs, but like we give them, like you're saying, we give them a package, right? Patients come to our clinic and you've done the best you can with immunological therapies and they still are heavily proteinuric. We give a package of, MR blockers with maybe SGLT2s and with ARBs. One important thing is the more hemodynamically stressful medicines you keep adding, the chance of AKI in the setting of any intercurrent illness is very high. So I give them a little paper saying, if any of these things happen, you have nausea, vomiting, diarrhea, you're made to not eat and drink for a procedure, stop all these medicines until you're able to eat and drink normally. And that has saved visits to the emergency room with AKI. And each time you get an AKI, there is some irreversibility. So these drugs are maybe useful. We're not 100% sure in membranous that they are that useful, but if you plan to use them, just be extremely careful that AKI should be avoided at all costs.
Do you recommend them for conservative approach?
Yes, I do that. If they're borderline like 3 grams and albumin's not too low, I usually start with combination therapies. And not SGLT2s, but the MRAs and ARBs.
So there's another question. Somebody is asking why Plex failed in membranous nephropathy with high titers of PLA2R antibodies.
No, so I think that's an easy question to answer, because if you're looking at proteinuria endpoint, you could clear the PLA2R very effectively with Plex, but you need to prevent the relapse unless you give immunomodulation to reduce the production. So Plex is not going to work. It's very temporary, and the antigens, antibody that is planted in the kidney and is activating complement will take months to years to completely clear. So it's not like anti-GBM where it's very, you see the effects very quickly, but in terms of antibody depletion. But in conjunction with very powerful medicines like cyclophosphamide steroids, the Plex will work in that situation. But membranous is a long-term issue. It's not going to help with the. I must say there are now these CAR T-cell therapies are now sort of being investigated in diseases that are associated with a single antibody. So you can actually genetically manufacture a T-cell that destroys anything that contains the epitope for the PLA2R. And then it's not in clinical production, don't get me wrong, but these thoughts, you look at review articles, they are being discussed quite widely in these diseases like anti-GBM and PLA2R and ANCA.
Do you see voclosporin as an alternative to because it's the new kid on the block? So.
No. So it's another. It's if you know the structure of voclosporin, it is cyclosporin like with one little side chain modified. So, and the only advantage of voclosporin is you don't need to check levels of cyclosporin. I don't think there's any difference, to be honest.
Okay. There was one more question. Somebody is asking, are there any studies showing extent of proteinuria reduction with ACE and ARB alone?
Right. So there was one study very, very early. It's in the 80s, yeah, by Brian Myers and his group. So you get a 20 to 30% reduction in proteinuria in membranous nephropathy with, it was an ACE inhibitor study. So yes, we do see reduction. We don't see a reduction in the patients who are heavily nephrotic, 10, 15, 20 grams. But these are patients who are in the moderate range, 3 to 5 grams. You can see easily a 20 to 30% reduction.
So hope we have come to an end of a very nice session. Thanks, Joy, for joining us. And thanks all the audience for their active participation and listening to this evening's academic feast. Joy, we have been blocked to your breakfast and the day. Hope it's early morning in your place.
No, it's almost noon, so yeah, I'll be heading for lunch very soon.
Oh, so then I'm wrongly taken.
Thank you, and you'll be heading for dinner, late dinner. Thank you for staying up late.
Thank you very much. I'm an excellent, crystal clear session. So I think it was a great learning.
Yeah.
Sorry to have you so long. Sorry.
And Manisha, lots of new things to learn about, the new trials, the reboot, the iptacopan, and all, which is personally from Joy's pocket. Otherwise, we will not learn at this time. So. So very nice, very nice.
Thank you.
I'm very happy.
Yeah,
very
my
happy.
pleasure. Yeah. And be well, stay safe.
So then I think I would like to thank
Over to
everybody who has
Padmini.
joined in. Yeah, everybody who has joined in, especially our expert panel for updating our knowledge base, and our audiences for their active participation, the Win India team, and last but not the least, our organizers and the technical team who made it all possible. So thank you for giving your time.
Thank you very much, and take care now.
Thank you.
Take care too. We'll see you soon in some other meeting. Swarnalata, we are moving out.
Yes, thank you.
Yes.
Thank you.
Excellent.
Thank you, everyone. It was a wonderful session. I think we all have enjoyed it. So we'll call it a day.
Yeah. We'll have similar one in June, I think, with
Yeah.
Dr. Barat.
Yes.
Yes.
Yes. And I have data of IgA nephropathy ready for that.
Okay, we will see it. We will see it in June.
Yes, yes.
Thank
yes.
you,
Thank
thank
you.
you.
Thank you. Thank you.
Thanks, everyone. Thanks, Padmini.
Thank you, ma'am.
Thank you, ma'am. I'm keeping it offline now.
Yeah, yeah.
Thank you.